I'm Joanne Kenen. I'm the journalist in residence at the Johns Hopkins School of Public Health. I've written a great deal about Medicaid over the years. I ran healthcare at Politico for about a decade, and we covered Medicaid on a minute-by-minute basis. The reason we were doing this on a Friday afternoon at 4 o'clock, I actually asked for it, is we were trying to accommodate a CMS official who, after 3 months of wrangling, decided not to come. Our Republican representative who did plan on coming I got an email at 5 o'clock yesterday. Commissioner Drew Goncharowski is also not coming, so we do not have we have a Democratic state and a nonpartisan expert. The lack of a Republican voice is, I couldn't find one in the closet somewhere at the last minute. But because we're at 4 o'clock on a Friday afternoon, we're also going to do very few slides and a lot of questions. We're going to just do a couple of minutes of slides. We're going to have a conversation. We'll open it up to questions. I'm going to introduce my two guests right now, and then we'll get going. Hemi Tewarson, who many of you have seen at AHCJ events in the past, sometimes with me, is the executive director of the National Association of State Health Policy, which is a great resource for those of you who cover your states. And Commissioner Kirsten Johnson is the DHS secretary, correct, of the neighboring state of Wisconsin. So thank her for coming from Badgerland to whatever they Gophers or something. So Hemi can talk about the national framework. During Q&A, she cannot really talk about what is X state or Y state going to do. She can answer your questions about national policy. And of course, we can talk much more specifically about Wisconsin. So I'm only doing 3 slides. And I wanted to thank them. This was a really hard, I think many moderators this year found it hard to get panelists. I've done HCJ webinars and conference events. I've never spent this much time trying to get people. I'm sure you're all having this frustration if people don't want to talk. I would have heartily thanked the one red state representative for coming, but then he didn't come. So thank these two. So these are our guests who I just told you, as well as their contact numbers. You can screenshot this. And I have some Medicaid resources that you all have places you're used to going, but I think these are a good representative. This is a complicated change to Medicaid. It's the biggest change, arguably, in its existence. So I'll see if I can get this on the HCJ website. And then I'm going to just turn it over now to Hemi, who's going to talk a little bit more about, you'll go your slides, and I could put that resource slide up again at the end if anyone just wants to screenshot it. Okay.
Good to see everyone here. Glad to be here. Thank you, Joanne, for hosting us. What I'm going to do in the next couple of minutes, probably like 10 minutes, I did want to just walk through the requirements. I will just say, talking to reporters on this topic, which I do frequently, sometimes there's things in the statute that folks don't realize, things where there's ambiguity, where states have flexibility to determine, and things we're waiting for federal guidance. So I thought it would be helpful just to set the playing field of here's what we know with respect to the requirements, and then really want to turn to Kirsten to talk about her experiences implementing those requirements in Wisconsin. So that's sort of the plan. I will just say, for those of you not familiar with NASHB, we are a nonprofit, nonpartisan organization in Washington, D.C. We work with all 50 states in the District of Columbia, and we really focus on how do we improve health. So Medicaid is a really big focus for us right now. We have different projects going on with different types of state leaders. One thing about NASHB that's unique and different from the National Association of Medicaid Directors is we have an academy that we work with very closely and really represents their interest to us. It's Medicaid directors, it's governor's offices, it's legislators, and it's other state officials. So when I talk about different requirements, I bring those perspectives to bear. So it's not just those who are in charge of the Medicaid program, because the Medicaid community engagement requirements impact a lot of different folks across state government. So I just wanted to say that. Okay, I will also say I'm a Medicaid lawyer by training, so I do like to talk about statutory provisions, but I'm going to try to make this very simple and straightforward for this conversation. So you all know this, but the one big beautiful bill, also called the Working Families Tax Cut legislation, that's how CMS refers to it, has a number of different requirements. And you have all these slides in the app, right? So they're available for you.
I did upload them, so they should be so the resources will be there too, and then we'll try to get them on the website.
Yeah, so you can see how many different sets of requirements states have to comply with and the different timelines in which they kick in. We're only really going to talk about community engagement today, but if there's things on these other sets of requirements that you want to understand, so the interrelation, you can bring that up during the Q&A. I will say, I have done Medicaid for a long time, for over 25 years. This is a lot of work in a very short time period for states to implement. So there is a big challenge in just getting into compliance and changing systems. And we're going to talk a little bit about what that means in reality with respect to community engagement. And it's across eligibility, it's across financing, it's across IT and operations, it's across reaching communities. So there's a lot of different buckets to think about when you think about how states are going to actually meet all of these requirements. Okay, so community engagement requirements. Let's talk about what they are. I know you all have familiarity, so just bear with me as I walk through them. The first thing is that in order to be eligible for Medicaid, starting in January 1, 2027, individuals have to demonstrate at least 80 hours per month of employment, work programs, education, and/or community service, or a combination of those 4 categories. So it doesn't have to be just in one category, or meet an equivalent amount of earned income during that month. So that's the fundamental change that we have not seen before with respect to people who now qualify for Medicaid. And who is it going to apply to? It's going to apply to expansion populations, and those are individuals who are 19 to 64 years old. There are 40 states in the District of Columbia who have expanded Medicaid, so it'll apply to those people. It does not apply to people who are 65 or older. I've had that question before. And it doesn't apply to people who are duly eligible for Medicaid and Medicare. So just know that right off the bat. It also applies to states that have waiver programs that provide minimum essential coverage. We have 2 states that fall into that category, people up to 100% of the federal poverty level that didn't meet the traditional ACA-defined expansion population. We have one on stage with us today, Wisconsin, and Georgia is the other state. So just to give you a playing field, we're talking literally about 42 states in the District of Columbia that need to comply with this. What's the timeline? So there's implementation requirements. All states have to meet under the statute January 1, 2027. And that means anyone who wants to apply and who is not already on the program starting January 1, 2027 has to demonstrate before they become eligible that they have met these requirements. That's another question I get a lot. How does that work? It's like you literally, before you're eligible for Medicaid, you have to meet these requirements. For those who are already on the program, it is when they are redetermined for their eligibility. So for some people, that'll be in January. For some people, that will be in March. It's going to be different schedules for different folks. And what the new requirement now states is once January 1, 2027 happens, people have to be redetermined every 6 months. So every 6 months, you're going to have to prove that you have met the community engagement requirements for that period of time. And I would say right now, states redetermine people once a year. So this is a significant change with respect to how frequently you have to check to make sure people are meeting the community engagement requirements and also everything else that would make them qualify for Medicaid. So just wanted to kind of put those 2 together. That's another question I get a lot from reporters. Because of the timing of when you have to notify, I won't get into all the weeds of this, but there's 90-day requirements of advance notification, et cetera. So most states are going to have to begin outreach to beneficiaries between June 30th and August 31st in advance of that January 1 date to let them know that this is coming, to let them know that they're going to have to meet these requirements. So communication to beneficiaries is going to happen very quickly.
Starting next week.
By June 30th, starting June 30th, so in a month or so. There is an opportunity in the statute for the Secretary of the Health and Human Services Department to grant a temporary good faith exemption to delay implementation. And I will just share, CMS did issue some guidance on this, so it's not binding. It's guidance they issued in December, and they said that approvals of the good faith waiver will be limited to states that are making meaningful efforts towards implementation and experience severe and/or unexpected issues that hinder their progress. Informally, that has been interpreted by states to mean don't count on a good faith waiver. It's going to be very special circumstances. We don't know yet how that may change. We will see if there's more guidance in the final rule that I'm going to talk about that's going to be issued on June 1st. But that is a piece that is in the statute that I wanted to make you aware of. The statute also requires that the interim final rule for these community engagement requirements has to be issued by June 1. So we have heard that we anticipate that rule to be released Monday afternoon, essentially, which would be June 1. And that is what states are really waiting for. They're waiting to really see in writing what is going to be, decisions by CMS where there is ambiguity in the statute, where CMS has discretion to interpret, where states may have discretion to interpret. How does that all look on paper as of June 1? I will say CMS did provide interim guidance in December. Again, that doesn't have the same binding effect as a final rule. So states have relied on that to give them direction, but it didn't identify all the different details and questions that states have. States have also been, CMS has also been providing informal guidance along the way and been meeting with states. But again, until they have that rule in hand, they don't know for certain that that's going to be the end result. Interim final rule, just for you all to know, we anticipate a 30-day comment period and then go into effect. So that's just the timeline. The other thing I just wanted to say too is there are a number of exemptions in the statute. I'm going to have the next slide on that to tell you about what those are. And a couple of states, even though January 1 is the date, a couple of states have decided to go early. So Nebraska was one. They went forward on May 1. Montana is planning to go forward on July 1. And Arkansas is planning to go forward on July 1, but it's a soft launch because they won't have any penalties for noncompliance until January. So just to give you a sense of some of the states that may be early to watch. Okay.
And Hemi, do we know that no other state is doing an early launch? Because that's something they can ask there. They have to decide by now if they're doing a soft launch?
They had to get CMS approval, so we're fairly certain. There might be, Iowa had said they might go early, but it looks like they may not now.
Okay, because I saw they were doing December 1st.
But that could change. Okay. Yes, but yeah, they all have to get approval by CMS to go early, so they have to be in conversations
and
with
by
CMS.
soft launch, we mean that it's like a trial where they run the system, but people have to comply with it, but they wouldn't lose their benefits during that sort of trial period.
Yes. Okay, so what does the statute say in terms of who's exempt from these requirements? This is a really important part of understanding how to implement and how it's going to impact different people. So pregnant and postpartum women, individuals, are exempt. And that, I just wanted to highlight, that means for people who are receiving postpartum coverage, which for just about every state across the country, that is up to 1 year after the pregnancy, they can remain on Medicaid and they do not need to meet those requirements. So I just wanted to highlight that for you all. Foster care youth, Indian Health Service members, caregivers, and that includes parents, guardians, caretaker relatives, or family caregivers of children under 13, or disabled individuals. I will just say one challenge with that, states don't always know who those caregivers are. In these other categories, you're able to determine just based on data sources, existing data sources. That's a category I've heard that states are using different strategies to figure out who will fall into that exemption. And Kirsten can talk about how Wisconsin is thinking about that. Disabled veterans, medically frail individuals. And I'm going to just spend a moment on medically frail. I think that's probably been one of the most talked about exemptions because I think there is ambiguity in terms of how states are going to be able to interpret that exemption.
Right, because there's some things states have to do. It's like written into statute. And then those of you covering this state, there's some things that are, the states have some wiggle room or discretion. And I've asked her to really, I think medical frailty is something that we're all going to be writing about, and I've also asked her to discuss mental illness and substance abuse.
Yeah, so I'll just talk about this briefly now. So in the statute, it defines medically frail individuals as people who are blind or disabled, have a physical, intellectual, or developmental disability, have a substance use disorder, or a disabling mental disorder, and those who have serious or complex medical conditions. And that's where there's really some ambiguity. Different states have different definitions of medical frailty prior to the One Big Beautiful Bill Act, so they are interpreting that language in different ways. And they don't yet have concrete guidance from CMS in terms of how much flexibility they're going to have to actually make those determinations. And just to give you a sense, some states are using different strategies. Some are going to use claims-based data to really figure out who qualifies. It's going to be based on CPT codes, for example. Which types of services are these individuals getting? We can put them into a category. That's how we're going to determine that they're exempt. They don't have to tell us. We can do that on an ex parte basis and be able to ensure that they remain eligible for the program. Some states don't feel like the claims data tells them enough, and they're not going to be catching everyone. So some states want to do a combination of claims review, as actually health screeners to really ask the questions, and self-attestation. So that's the part where I think there's not 100% clarity in terms of how much CMS will allow states to do, how much leeway they will have with that respect to that particular exemption. And that's what we're really waiting for the interim final rule to see what will be actually allowed for states. There are some states, just so you know, their legislature has decided they cannot use self-attestation for this exemption. Utah and North Carolina actually are prohibited from using self-attestation. So that's something, just when you're reporting on this, just be aware, whatever state you're looking at, there are going to be sort of variations across states with respect to how they approach this. And we can get more into this during the Q&A. The other exemptions are people who are participating in drug or alcohol addiction treatment, individuals meeting SNAP or TANF work requirements. So if they're already meeting those requirements, they are exempt from separately meeting the community engagement work requirements, and individuals who are currently incarcerated or in the last 3 months of being incarcerated. So that's all the required exemptions. These folks have to be exempted out of the program. Then there's a set of optional exemptions for states to decide whether they want to actually use those exemptions for their programs. The first category is individuals receiving care in hospitals, nursing facilities, or other intensive care settings, individuals in federally declared disaster areas, individuals living in counties with high unemployment rates, and individuals or dependents who are required to travel outside their community for medical care for an extended time. So those are optional categories. States are defining those differently, and you will see some variation in terms of how states decide to actually implement. Okay. I'm almost done with my slides. I just wanted to make sure we got through all of these so people understood all of the different themes. Okay, there's a couple of other statutory requirements I just wanted to explain. So I talked about how individuals have to comply with these requirements when they apply and when they renew their coverage. That means, current enrollees must meet the requirements at least 1 month in each of the 6-month period. So, you're looking back 6 months, have they done all the things that they need to do with respect to those work or education or engagement requirements? States do have an option to decide when you're looking to see if someone has met those requirements, do you look back 1 month or do you look back 3 months? And different states have opted to do it differently for the ones that we've spoken to. So in some states they may say, okay, you apply on January 1. I can only look back as far as December 1 to see if you've met all of the 80 hours basically of requirements. Other states can decide, we want to actually look back 3 months, so they really have a longer period of time to meet the requirements and a longer time to demonstrate whether they're actually going to be in compliance. So when you think about reporting on this, just keep that in mind, that is a distinction. States also have an option to redetermine eligibility more frequently than 6 months. So right now, the federal minimum is every 6 months. I have seen some states that are thinking about doing it more frequently. We will see if that actually comes to pass, but that's something also to keep in mind, which means you would be checking more frequently too, not just on the community engagement side, but also if they continue to qualify for Medicaid on the other sets of requirements. The other requirement that I really hope you all sort of keep in the front of your mind, because this is an interesting one, states are required to use available data to verify compliance as much as possible before requesting additional information from applicants. That is in the statute. The statute really envisions that states automate. some of these pieces, which means not requiring the individual to fill out a ton of paperwork, to do a lot of additional work on their behalf to actually comply, but actually where can states tap other databases, understand what information they already have of that individual, whether it's through their SNAP program or their TANF program, or their employment records, or thinking about educational databases. These are all things states can tap to understand whether that individual can meet the requirements. That's what we think that the statute envisions, and we're going to be really interested to see what the interim federal guidance says about the automation part of that process, because states are really trying to move in that direction. And managed care organizations are prohibited from making the determination of compliance. You can't have your MCO make those determinations. So what happens if someone doesn't comply? What is the process? States have to follow this process by statute. They have to provide a notice to the individual, and the member has 30 days to remedy. So that's an important part of understanding, what happens. And if they don't remedy, then they will have to be disenrolled, but they can re-enroll. So that's another question I've gotten from a lot of reporters of okay, what happens? Is there a 6-month ban and they can't come back? No, there's not a 6-month ban, but there has to be enough time that they can show they meet the requirements before they come back into the program. So that's that piece. And then on funding, this, as you might imagine, is a pretty big undertaking. The funding that was available in the statute, under the statute, was $200 million to CMS and $200 million for the states, for CMS to distribute to states. Not a ton of funding when you think about the resources needed to actually change these programs. So states have had to think about how much do they ask their own state legislatures for, building out capacity, for example. And on the IT side, I would say there is a federal matching rate available for any new build on IT. You can get a 90% federal match rate. So for states that have to build out different eligibility processes or buy new systems, there is a 90% match of those dollars from CMS to states to meet that requirement. So sometimes people don't talk about that piece when they talk about funding, and I just thought it was important to call that out. Okay. I'm almost done with my requirements, and I'm going to let Kirsten talk about Wisconsin, what it means in their state. So the last thing I'll just say is, what does this all really mean? A couple takeaways I would just share is there has been limited time to plan for really serious and significant implementation, and at the same time, states have had to kind of make their best guesses because they don't have the final guidance in hand. So a lot of work has been done. States are working, in good faith, but they didn't have the final regulations, so we're going to have to see, what happens when those are released, and that's again on Monday. There's a lot of variability across states, so it's really unfortunate we don't have Nebraska here, because you would hear from Drew. They have gone live on May 1. They have a smaller Medicaid population. They have an internal IT system that they control themselves, where they're doing a lot of work to match and understand who meets the exemptions and who doesn't, and they've moved forward ahead of other states. Their Medicaid population looks much different in size than, a California, a Wisconsin, an Illinois. So there really is a lot of variability across states. There's also a lot of variability across IT infrastructure. Some states are integrated across their programs. Some states have eligibility determinations that are outside the Medicaid agency in a completely different state agency. Some states have really old legacy systems that have been it's taken a lot of work to try to get them ready to have this kind of automated data feed. So states are in slightly different positions on that, and I think some feel more ready than others in terms of their IT capability. There's a lot of cross-agency coordination. I've done state policy work for a long time. I think there's some states that have been, they all coordinate, but some states just had a built-in structure that had much more easily and quickly and readily available cross-agency coordination on this topic. Other states have had to build that as they've gotten ready for this requirement. So states are at a different stage on that. And then availability of data. I think all states have, this is a new way to think about Medicaid, so all states have had to figure out those data sources, but some have had some more readily available. I'll say, example like Maryland, they have a health IT system where not only only claims data, but also all the encounter data across payers. That's an amazing resource for Maryland that not all states have. So when you're thinking about what you want to look for data matches, they have a set of resources that other states may not have. So I just want to point out some of the variation. And then the last thing I'll say is, I think one of the key pieces to really successfully implement this set of requirements is engagement of people outside the state agency. And that's like providers, health plans, community groups, and others. How do people really understand what's going to be in front of them? I mean, I think we all get different sets of requirements and forms, and I'll say, I'm terrible about it. I never want to send that back in. I don't want to respond to that email, right? And so you really have to get trusted voices with folks to explain what these requirements are, why they matter, and really be able to reach people where they are so they can have the best set of tools available to navigate all of this. So I think I will stop there.
Okay. Before we go to Wisconsin, which is a state, we'll let the Secretary explain the unique things about Wisconsin. I just want to recap a couple of things because that was a lot of information, but we needed to get it all out there. One thing I have seen some very good experienced reporters get wrong, and she did point this out, I just want to point it out again. It is not everybody on Medicaid. You know, it is the expansion population, which means some of the conservative states that might not have implemented this very well don't even have to because they never expanded. So that's one thing. Two, we call it work requirements, and for most people that's what it will be, but education does qualify as work, and community volunteer work, basically community engagement, and we'll sort of, that's a lot harder to like data matching. You know who's getting SNAP, which we used to call food stamps. You know who's getting TANF, which we used to call welfare. It's a lot harder to sort of figure out what qualifies as community engagement, and if you think you're doing community engagement, your state doesn't, you're in trouble. So we'll see how Wisconsin's doing it. And also the phrase data matching, which you used, which I didn't totally understand it when I was preparing for this. It means, like, instead of me having to go and prove that I am doing this, my state has to see if they can find out first by using whatever records, SNAP, TANF, education, college enrollment, trade school, all the community college counts, lots of things do count. So, but it's also a really heavy lift for states to do all this in 1 year, or a year and a half since the last July. So it's about 18 months or roughly to do all this, and the rule, like what they have to do, they're going to find out. I mean, they've had some information, but like really solidifying that, it's not going to be till next Monday. Okay, and they have to have this. And then the other thing is, most of you are familiar with the phrase unwinding, which was there is routinely some recertification of Medicaid. During the pandemic, it was sort of put on hold, and then everybody had to recertify in a fairly short period of time. It was 3 years worth of recertification. Am I getting it was 3 years, right? And it didn't. You all remember it didn't go well. Lots of people who actually qualified did have trouble staying on Medicaid for a while. People move, low-income people move. People don't have. They speak a lot of different languages. Maybe some of the lessons learned, which may be another question for Wisconsin. So I don't think any state had a great rewinding. So what have you learned from? I mean, that's something you can ask your states. I was excited about doing this because this is a huge national story and this is a huge local story. This is a tremendous change to Medicaid and how we have covered people. And someone who's really written about this for many years, I think it's really important. And it's complicated, so when we get to the Q&A, that if you don't understand something, there's no dumb questions. Really feel free. This is your chance to ask people. It's very complicated. And it's technological, we don't want to spend the whole hour talking about data, but it's really complicated to get this system up and running, and we all have some nightmares about past government health and education related websites. So with that, I think the things I wanted to quickly point out before we change to Wisconsin, just take it away.
Thank you. Thanks, Joanne. Again, I'm Kirsten Johnson. I'm the Secretary at the Wisconsin Department of Health Services. For those of you who are not from Wisconsin, Wisconsin Department of Health Services is a super agency. So we have public health, quality assurance, which is nursing home, long-term care. We have care and treatment services. We operate 7 hospitals, mental health facilities, as well as behavioral health, mental health services, and we also have public health. So we're broad. And Medicaid, obviously. And our Medicaid team also operates SNAP. So this 18-month timeline, that's the same team that does eligibility in Wisconsin for SNAP are the same team that's working on eligibility for Medicaid. So it is a lot of work for the Medicaid team over the course of the last 18 months. And I would argue we did pretty well during the unwinding.
Okay.
So Wisconsin, I'll give a little background on just Wisconsin Medicaid. So we are unique. We have about 1.25 million people who are covered by Medicaid in Wisconsin. We call it Badger Care. But that population, we are a non-expansion state with the caveat that we did expand to 100, for single adults, up to 100% FPL. On our own tax dollars. So we do not get the matching, the 90-10 match that other expansion states get. So we are covering roughly 180,000 additional people since 2012, and we have paid as a state $2.4 billion of our own tax money to cover those people because we did not get the match. Yes, it was an interesting model. We are a state with, at the time when that happened, we had a Republican governor. We now have a Democratic governor and a Republican legislature. So we're purple. We're leading into an election in November, which we'll see what could change to some degree. But that has absolutely contributed to how our Medicaid program is set up. So like I said, 1.25 million roughly people are covered by Medicaid in Wisconsin, expanded up to 100% FPL. There are about 180,000 people who are going to be, that with the work requirements would impact them. We think roughly of that 180,000, 63,000 are actually going to be impacted. And as Joanne mentioned, we are working very hard to think about how can we reduce that administrative burden for those people specifically. So we are looking at SNAP data. Our eligibility system is integrated, so with SNAP and TANF, so childcare, SNAP, and Medicaid are all on the same eligibility system in Wisconsin. Wisconsin has also invested over the course of the last number of years in our technology. So we have a very robust technology system, which did help us during the unwinding. We learned a lot. We continue to invest in our system. We also have an app. It's called My Access. I actually went on it yesterday to try to get in. I couldn't get in, but when I downloaded the app on my phone, it had 12,000 five-star reviews. So I say that's pretty good for a government app, but it is very effective for our Medicaid members in terms of their re-enrollment, having to enter information, and we leaned in heavily during the unwinding to make sure that people's phone numbers and emails and all of their information was updated. So we've done a big push during the unwinding, which frankly I think will help benefit us while we look at the work requirements. And the other things I just want to add is as we think about how we are implementing this in Wisconsin, we're really trying to be person and human centered. So we're trying to make it the information as accessible as possible. We have a widget that's ready to go on our website so people who maybe aren't impacted but are covered by Medicaid can go on and identify if this could potentially impact them. We're hoping that'll go live in the next couple of weeks. We're really trying to think about how do we do the right thing and how do we get it right? So we are not planning to go early. We're taking our time to make sure that when we have to go live on January 1st, that we can get it right, that all of our technology is in place, that our eligibility teams are ready to go, that people know what needs to happen and how we're going to do it. We're going to be very clear in how we communicate. And then finally, we're really leaning into this technology. Like I said, we have invested over the course of the last number of years in our own technology. We have the app. But then the technology match for CMS for Wisconsin is 90-10, which we don't have otherwise because, again, we're this unique non-expansion state. So really trying to take advantage of how do we invest in this moment to make sure that we are truly human and person-centered. And of course, we want to be good stewards of taxpayer dollars. But absolutely want people to continue to have access to health care because they need it. I think I'll stop there and just open for questions.
So one of the questions I have, I mean, the work requirement is not full-time. It's basically half-time. It's 80 hours a month, correct? And it doesn't have to be 20 a week. It's just 80 hours per month. So like, if I am dutifully trying to do this, is it like a one strike and you're out? Like, okay, let's just say I've done 75 hours and then I get the flu and it's the end of the month and I can't get my last 5 hours. What happens to me? And is that a state discretion or is that federally mandated. Like, the person who's working and then, they break their leg, their mother dies, whatever. Something happens and you're 5 hours short or 8 hours short or, 90 minutes short. Do they lose health care? Because I don't really understand that.
So I think that's state dependent.
Okay.
So the way we're approaching this in Wisconsin, and again, we're waiting for the rule to come down on Monday, but the way we're approaching this in Wisconsin is we're looking, if somebody's currently a Medicaid member and they have to have their eligibility is coming up, let's say next March, for example, or a year from now, next June or May, we are giving the opportunity for a 12-month look back. So any 1 month in those 12 months, you have to show that you worked for 80 hours or volunteered or were in school. Because we also have a population in Wisconsin and in many Midwest states where we have seasonal workers, people who are working on farms, who are working in different types of positions in the winter or in the summer, then that impacts the hours they work. They may work 100 hours a week in the summer and work much less hours in the winter, and we want to give them an opportunity to keep their health insurance.
And is that pretty
No, every state is different.
Okay, and do we know anything about how rigid some of the states are going to be, or we don't know yet?
I think many are waiting to see that interim final rule to see what is going to be allowed. And some states I've talked to, it's going to be a 1 month look back. That's what
And
they're
so
anticipating.
that for new members, for us, will be a 1 month look back.
Because that's
starting in
mandated,
January.
right? So if you're already in Medicaid, states have some discretion about how they define compliance over what period. You just said it could be a year, but for
It could change based on the rule. I want to. The caveat here is it could change based on what comes down. But our
CMS
intention
should have just known that we were having our conference and dumped the rule a few days ago. It was very inconsiderate of them. In addition to not showing up. Well, they didn't not show up. They ended up not saying. They didn't just not come. They said they weren't coming after 3 months of begging. Yeah.
Just to maybe put a finer point on what Kirsten just said. So for newly enrolled applicants, states have a choice between a 1 or a 3 month look back. So I just want to say that a couple of times. So you can just look back 1 month to see if they meet the 80 hours, or you can look back 3 months to see if they, and if in any one of those 3 months they met the 80 hours, or across those 3 months, they can continue to qualify. I think an open question is for those who are currently eligible. Some states have interpreted they can only look back 6 months.
That's a caveat. I need to add that caveat. Thank you for naming that.
Yes.
So we are looking back 12 months because we are a non-expansion state.
Yes.
So we only have to verify eligibility once every 12 months. Us and Georgia, we're the only two states that have that.
Yes.
You're a partial expansion. You're not a traditional
Correct.
ACA expansion,
Thank you.
right?
Yep, and that is a critical point. So we only have to look at eligibility once every 12 months.
Yes, and they are the only two states who, the rest of the expansion states have to do it every 6 months.
Is
So-
Margaret here from Atlanta? Okay. I promised you the first, if you want to jump the line, I promised you could, or you go to the mic, or you just wait your turn. But I wanted her to speak because the Georgia Medicaid official who Georgia has they already have a work requirement. I believe he truly could not attend. I believe he had a genuine conflict. I know him, and I don't think I also know the school calendar there. So I think it would be good for you to. It's one of the two states have already done this. Most of you know this, but for any of you who are new to the beat, under the first Trump presidency, several states tried to do work requirements. The courts eventually struck it down at that point. Arkansas did launch, and it was a technological disaster. I did ask them to come and tell us how they were going to do it differently this time, and they politely declined. Their apps didn't work great. Their communication didn't work great. There were people who were, in fact, working. They didn't have access to broadband in the right hours that you could use the app. It was a technological meltdown, and it was something like 17,000 or 18,000 people lost coverage, most of whom were actually working, right? And then the courts threw it out anyway. Don't use that number without asking someone who remembers better, but it was really, it didn't work well. So that's sort of, states have to do a better job. Georgia has also had problems, which Margaret can talk about in a second, in that there are people, it's not as big as Arkansas, but there are people who are working and who are having trouble verifying it. So the technological lift is heavy, both in terms of do you design a system that works, and how easy is it for people to use? Is it available 24/7? Is it multilingual? There are just a lot of questions, because but the flip side, and this is sort of interesting, is if states do a good job, and some will, including some conservative states, and some won't, including some who might try to and mess it up because of the complexity, if they do a good job, a lot fewer people than forecast will actually, the forecast is about 5 million people losing coverage over 10 years, right? Yeah, I think it's 5 to 6 million over 10 years. But if the states really step up and the technology works and the outreach works, there could be fewer people, and also if it's like 50 states look like Arkansas, it could be more people. So go ahead for questions.
Hi, my question is on the role of the Taxation and Revenue Department within any state, because if you plug in your social security number or EIN, theoretically you could access information as to whether someone has worked and use that in your data points along with SNAP and TANF, et cetera. Are states going to be tapping into tax records to determine if people have been working as part of these metrics? Thanks.
I can't speak for all states, but yes. So we are working, for example, with our unemployment, Department of Workforce Development. Yes, we are looking to making sure that we are checking every sort of data point to see what people's income has been. I mean, we do that for income eligibility already. But again, looking at are they earning money and how much is part of our process. But again, looking at unemployment and thinking about all of the data points that we have available in states, we are doing that. We're doing that in Wisconsin. I imagine most everybody is.
Yes, yeah. I think the vast majority of states, if not all of them, are using their available.
Tap into like the tax records of the people that are applying.
I can't say for tax records specifically, but I know that we do pull people's income. I mean, that's how we verify their income.
Yeah.
Can states get into federal tax? Well, you could use your state tax records.
Right. State tax records,
right.
yes.
Yeah.
Hi, my name's Natalie Eilbert. I'm a former statewide mental health reporter from Milwaukee Journal-Sentinel, currently at the Cap Times doing opinion editing. I want to ask about the exemptions and optional exemptions. I will be the person asking about the sort of squishiness of those exemptions. I used to do reporting on how difficult it is to actually get recognized for a severe mental illness, going through the process of getting the neurological exams, going to get the psych evaluations that would actually deem you worthy, or not worthy, eligible for disability benefits, all those things. So it's a really hard, long, and Kafkaesque experience. So I'm curious if you can talk a little bit about these more, the illnesses that have historically been misunderstood and misdiagnosed, and how that's going to complicate the way that Medicaid coverage is recognized. Thank you.
I told them on our prep call that there would be a lot of interest in that topic and in substance abuse treatment. So your turn to address it.
So I'm happy to share, not specifically to any state, but just general themes and talking to states about how they've thought about this exemption, and it is a challenging one. One issue that's come up in talking across state leaders is, especially if someone's not eligible yet for Medicaid, but they need access to services, that is going to be very difficult if they haven't yet sort of gotten the diagnosis and they haven't yet been seen by providers for which the state has access to those claims data. So that's just something I think each state is going to have to work out. I would also say sometimes those individuals fall into different types of exemptions, so it's also going to be figuring out where else they could fall. There's flexibility, I think, overlap across the different categories of exemptions, and each state is going to approach that somewhat differently. But those who are currently eligible, they may fall into another exemption, and when you look at their claims data, when you look at the other data that you may have about the individual, you may find that they meet something else besides that one severe mental illness exemption.
And I would just add, we are thinking about collaboratively, so states are talking to each other, our Medicaid directors are all working together to come up with sort of universal diagnoses codes that would be exempted from the work requirement. I think part of it is we're also waiting for the rule. We don't know exactly what it's going to say in this space specifically, but thinking about diagnoses codes, we are concerned about if people have not yet gone to a provider, but they need to be diagnosed, that definitely is a caveat. But also thinking, those squishy, have been hospitalized or are in a hospital. I mean, we are, again, waiting for the rule to drop, but trying to interpret that in a way so that if someone is hospitalized, for example, for a psychiatric disorder, that would count as an exemption in that, if they're hospitalized, period, in that eligibility timeframe.
And does an ER visit count? No, not necessarily. It would have to be.
Again, we're really waiting to see what the rule says before we make our final decisions, but trying
Because
to
it could be
allow for
voided
people
in-
who have not yet been diagnosed and potentially are, but have touched the healthcare system in some way.
Phil?
Yeah.
Hey, Phil Galler with the KFF. Thanks for all showing here. 3 related questions. You mentioned in Wisconsin that 63,000 of the 180 will be affected. Are you saying you know that the other 117,000 are already meeting the work requirements based on your data? Can you give a little more detail on that? And also, I wonder if you could all talk about the volunteers. Do you have groups out there saying, oh my God, they can meet this through volunteers? How are you going to check the volunteer records? Because typically there's not reporting to the government about your volunteer work. And then lastly, Nebraska got implemented with a very broad self-attestation. CMS let them go and say, anything you do, you can self-attest for anything other than work. You can self-attest to. Are you hoping that that's allowed when the rules come out Monday?
So I can speak specifically to Wisconsin on the 63,000. Yes, so we've run our data to try to identify people who would be exempted, who fall into the 180,000 who need to meet the work requirements, who would be exempted on existing information that we have on that 180,000. So that 63,000 is the space that is less clear, but they may also be exempted in some cases, but the rule's not final, so they are just fallen into this gray area that we're not sure about them necessarily. I will say on sorry, now I can't even read my own writing.
None of us can either.
Yeah. I forget what the other questions were, but. Oh, so the volunteers, the self-attestation is another. We're not sure what's going to come out in the rule. But initially, the conversations again with other states thinking about how are we all going to do this? We're all going to be faced with this challenge, waiting for the rule to see what the parameters are on that self-attestation. And
Maybe explain, in case anyone's not familiar with the phrase, what we're talking about by self.
So
what are they
someone
attesting
would
to?
potentially would just have to sign up and say, yes, I volunteered for 80 hours, and they would check a box and say, yes, I did, and we would accept their word as true.
Or I have a severe illness.
Right,
Check.
exactly, check.
Are you hoping they do that though? I mean, do you have a preference one way or the other?
I don't know that we have a preference. I think we're just really waiting for the rule. And my preference is, like I said earlier, that we are making sure that people who need access to care can continue to have access to care. But being thoughtful, I mean, we are all, again, when we run these state agencies, tax dollars are tight. We want to be good stewards, absolutely. But at the same time, want to make sure that, those people who may fall in the gray area can still have care. Yeah.
Okay, next, Mark.
Hi, yeah, I'm Margaret Coker. I am the co-founder of Georgia's nonprofit investigative news organization. We're called The Current GA. We're also a local reporting partner with ProPublica. And last year, together, we did a year-long investigation about Georgia's Medicaid work requirement experiment. And it was disastrous. Like, all the data shows that. And so just as a very brief takeaway, one of the most disastrous things about it was the technology investments. Georgia spent nearly $100 million for their technology partner and project manager, Deloitte, to build out the enrollment and verification system for the work requirement policy. And none of the metrics for success included enrollment numbers. So Deloitte gets all the money and Georgians don't get enrolled. And so, as of today, around 16,000 people are enrolled in the Medicaid work requirement policy right now. That is out of approximately 250,000 people eligible. The state's own data shows that 60% of that large group would meet work requirements, but the tech platforms are so glitchy and so cumbersome that people can't access. So, major takeaways. And I would consider that to be kind of one of the worst practices of 50 states trying to implement this. Nobody was actually physically kicked off for non-compliance because Georgia abated all of the verification programs because they knew that the tech was so glitchy. So, I have a question for you, Secretary Johnson. In the thoughtfulness of Wisconsin building out their tech platforms, who is your technology partner? And how are you thinking about linking enrollment to that success? And Hemi, if you could tell us with all of your, the academy and the knowledge base that you have with all of your connections, is there a state moving forward that you would consider just from a systems point of view or an analytical point of view that would be considered a best practice as we are still rolling out here? Thank you.
So I will start by saying one of the reasons we have invested in our technology. That was in 2017. We did submit a waiver to CMS for a work requirement in Wisconsin. It was approved and then put on hold because of the pandemic. And then in 2021, the Biden administration threw it out and said, this is not legal. This is not legal. We're not allowing you to do this. But because that it was on the docket for almost 4 years, there was technology behind the scenes that was working, and similar. And we learned from Georgia that if we were going to put this in place, we really wanted it to be well done. But because we had started some of that work in 2017, which is really why we started to invest in our technology platform, I think it has positioned us better now. Now, I can't say for certain we are not running pilots. There are states that are running pilots right now or starting to run pilots in the next month or two. We are not one of those states. We know that technology, even when it's functioning perfectly, there are glitches. We anticipate that, but again, we are trying to be very thoughtful about how we're investing in it and how we're rolling it out.
And what companies are you using as your?
And we're all using the same companies.
So that would be Deloitte.
Yeah, we have Deloitte.
Thank you.
We also use we use Gainwell. We all use them. Well, we're all using most of the same
So
companies.
before we go to the next, I have a quick question. So if a state's app or website or whatever is like nightmarish, do you have discretion in the first few months to waive anything or let people stay? I mean, if, say CMS doesn't allow self-attestation or in very limited circumstances, but I mean, the chances of at least one state having some kind of glitches or bugs,
Would that be the delay that everybody thought that the feds would not do? But if like you're having a crisis in your technology, can the feds put the work requirement on hold?
I mean, there's a lot we don't know.
There's a lot we don't know.
We don't know.
And I think that's to be determined. It's in the discretion of the secretary whether they're going to grant a good faith waiver to exempt or delay the actual implementation. That's, without that waiver, states are required to actually put all of this into compliance. And I'll just follow up on is there a model state? I think it's too early, honestly. I do think when you think about reporting on particular states, do take a moment to understand their own tech journey. I know it seems wonky and weedy, but it does matter. If Nebraska's here, they would tell you they do not use a vendor for their IT system. Everything is in-house. Is that better? Is that not? I'm not here to judge, but it's just a factual difference when you think about how they're building out their systems. They're not having to negotiate with Deloitte to make, as one example, there's others, to make changes to their IT systems. So I would say another thing just to know about across states, there are some states that are fully integrated. I don't know if Wisconsin
We're fully
is.
integrated.
So you could talk about that. Does that help? I don't know.
I think it helps in this instance,
Yeah.
absolutely, because we have our SNAP data, TANF data, it's all in one place. And it helps, from the consumer's perspective, from our members' perspective, they can be enrolled in all of the programs at one time. Yeah. And I just want to add on the Nebraska note, I think it also depends on scope and the size of the Medicaid population.
Yep.
We have 1.2 million. I think Nebraska has 300,000. It is a significant difference in the demand on your technology.
Well, that's a perfect segue to me.
Yes.
Since I was a long-time healthcare journalist, I'm now at the California Healthcare Foundation. My name's Lisa Alaferis, and yes, I'm in California. We have 14 million people on our Medi-Cal rolls, Medi-Cal, Medicaid in California. 5 million in the expansion population. We're estimating we're going to lose 1.4 million because of this. But my quick question is, first of all, did I hear you right that it was $100 million Georgia spent? Okay, Georgia, so for everyone in the room, there's $200 million in federal match fund, and Georgia just spent $100 million. So
That was as a waiver. That wasn't for this fund.
Yeah.
But in cases of how much it costs for states that implement technology, that is one case study of how much it does cost.
yeah, $100 million. Okay, that's what I'm saying. I'm saying it's not quite, but anyway, it's just correct.
Can I just stop you right there? Because for the IT bill, there's a 90% federal match for those funds. So it's not subject to the $200 million I talked about earlier.
Okay. Whoa, that is great information. Okay.
I want to add too that, again, this is a scope and states are different. So our build out for the work requirements is 10 million and
Yes.
Wisconsin, Texas is going to be $1 million. But so every state is different depending on how we've invested in our technology over the course of time.
Yeah, and the match does apply for that piece of it. It's
That's
really
really 10 million
confusing,
is a
right?
very helpful, though,
Yeah.
point of reference. Yeah.
And like Phil, I have a question, but mine's on education. So is it just part-time or full-time student? Because a full-time student is not in class 80 hours in a month. So I'm curious how that's being parsed out.
I'm sorry, I missed the first part of your question.
How do you define full student, that you're not in a classroom for 20 hours a week?
Oh, how do you define full-time? How are you doing it?
I don't know. That's a great question. I'm not sure. I think, again, we're waiting on the rules.
Okay, and my final one's a little more tricky. How are you reaching out to people to re-enroll them? Is this calling? Is it email? What is it? And then I have a quick statement at the end, and I'll be done.
Okay. It is all of those things.
Yes.
And again, I think we learned a lot from the unwinding, and I don't want to speak on behalf of all of states, but we really were able to hone in, and how do we assure that we have accurate contact information for our Medicaid members. I mean, I do think that is an advantage of having just gone through the unwinding. We in Wisconsin have a large number of engagement opportunities with our Medicaid members, so we have key informant groups that we meet with regularly. We have coalition groups that we meet with regularly that are meeting with their county eligibility teams. So again, there's been a lot of effort to build the relationships with actual members so that we can get the information out to them. Like I said, we have been very actively thinking about how do we, people are reading about this, they don't know what it means. We are working on this widget to put on our website. So all the ways we can engage to make sure that people know that this is happening. And in Wisconsin, again, we do have an advantage. It's a 12-month eligibility, which is the same as it's been. So we're positioned in a way that it doesn't necessarily change the cadence for our existing members.
Yeah. Can I add one other point too that hasn't come up yet? There are some states that are also, they combine their navigator programs for Marketplace and Medicaid. They already do that in some states for those who have a state-based Marketplace. And for those navigators, they're also going to be part of this process of making sure that people who are asking about where do I go next for coverage, like what are the different options if it's not Medicaid, if it's something else, Marketplace or otherwise. And there also will be there as a point of contact for folks coming back into the program. So that's just
and we similarly in Wisconsin, we built up our navigator during the unwinding that's covering Wisconsin, got a pot of dollars to support them to continue the navigation work. They were enrolling people in the ACA plans or in Medicaid, and we are again leaning into covering Wisconsin to help.
Okay, and my final comment is, are you using any AI agents? I'm guessing no.
No.
Okay, California, we have what's effectively a pilot, it's a company, it's partnering with a Medi-Cal managed care plan, it's an AI agent, it's calling out to people, 27 languages, 24/7, re-enrolling people, 96% re-enrollment rate. I just say that because we've spent a lot of time on AI here at this conference, and I've had somebody literally roll their eyes at me when I said I worked on AI, but there are a lot of AI solutions coming that are going to be very helpful in situations like this.
I just want to point to Cody Kinsley, who's back there, who's the former Secretary of North Carolina, and I think it was Cody who said one of the first times I met him is AI is really valuable in the places that are dull, dirty, and dangerous. Was that you that said that, Cody? All right. And I think we do a lot of things in government that are dull and are process-oriented, and I think there's true value in thinking about how we use AI to do some of these things. Absolutely. Yeah.
That sounds very Cody.
Yeah. It is very Cody.
Yes. Please.
Hi, I'm Felice Fryer. I'm a freelance writer. I work mostly in Rhode Island and Massachusetts, and I'm here because Joanne said stupid questions are allowed. So this is a very basic thing. If I am in the expansion population and I am exempt, fall into one of the exemptions, do I still have to recertify every 6 months?
Yes,
I don't think that's a dumb question.
Even if I'm exempt, I still have to recertify? Okay. And
well, can I just say, you have to be checked. So if it's an automated process, the state will recheck at 6 months to make sure you still
and you'll get some notification.
Okay. And if I'm not in the expansion population, do I still have to recertify every 6 months, or is that only for the expansion population?
That's a great question. I don't know because we're on the 12-month.
Yeah, you're in 12 months. I believe, I'd have to double check, but I believe that every 6 months is only for the expansion population.
Okay.
I think that's what I've read too in prepping for this, but it is, my list of questions got very long as I prepared for this.
So, and you mentioned the unwinding, which we called redeterminations. So the states, are there any lessons from that experience? Like the states that did well with that, some states did okay with it. Are they in a better position implementing this change?
I would argue we all are, even if we didn't do well. And like I said, I think Wisconsin did well because we had to go through that process of contacting every single Medicaid
Right,
member.
so there are some similarities there. Okay. thanks.
Right, because I mean, your contact information.
Right, is
and
so
there
critical.
should be some lessons learned even in the states that did a bad job.
And can I just provide a very concrete example? I won't name the state, but one state that, a couple of them actually during the unwind said, we never texted our Medicaid members before unwind, which in this day and age, right, we all get texts, we're all on our cell phones. So they built different infrastructures around that. That's just a small example of how you engage Medicaid members change during the unwind, which hopefully will help as we think about this set of requirements.
Jason? We don't have that much more time because the members' meeting is at 5:30, I believe, right? So everybody talk as fast as me.
So I'm Jason Kane with NBC News. We do a lot of reporting on home and community-based services, and a lot of caregivers nationwide are very worried about what's coming. They're worried they're going to get caught up in the paperwork and lose their coverage, which will be disastrous for their families. And they're also worried about the sheer amount of money that's going to be coming out of the system, and these programs are often waivers and are optional, and so they're going to be ripe for being cut. Do you have any thoughts on this? Do you think that they're right to be worried? And how I'm just looking for your thoughts on it. Thanks.
So that's a much broader question than community engagement, obviously, or work requirements. I mean, you're talking more broadly about with Medicaid budget changes, with financing changes, what's going to happen to home and community-based services? Is that sort of the
I think it's two parts. It was one part, like if I am a caregiver.
Okay.
Like I am.
That's the part one.
Right. And part two is what George Benjamin was talking about. Even though this federal statute doesn't change a lot of other things in Medicaid, there's going to be a lot less money in the system.
Right.
And states are already beginning to, and this is a great story for all of your states that are either in session or about to be, like, our rural hospital is going to close, our home and community services as opposed to institutional settings going to be cut. I think there's a lot of budgetary ripple effects. That's a good story for all of you, and we don't know if it's little or big or where it's going to hit, right? That's a fair.
Yeah,
but it's not, the statute didn't say you can't do that anymore,
right.
But you're going to have less money to do it depending on how many people lose coverage. If the coverage isn't as severe as forecast, the cover losses, then the economic impact isn't as much. The coverage could also be worse than forecast, in which case the rural hospitals are very worried. Well, all hospitals are always worried, but they have.
So maybe I would love you to answer the caregiver question, but I can talk about the broader HCBS and what we've heard from states directly, state leaders. I would say it varies across states in terms of where their budgets are and where they're going to have to prioritize. We have not heard from, I would just really wouldn't be honest in this room, from a large number of states saying we are going to have to cut home and community-based services because we can't make ends meet. It is voluntary and optional service, so that's why it is on the list of things that states can look to if they have tight budgets. I point to the example of Colorado. Colorado was very public. They had a very tight budget. Even before the One Big Beautiful bill, they had to make a lot of hard decisions. They made some decisions to think about expanding wait lists, eliminating the number of hours they would provide to paid caregivers, things like that, holding on increasing home health incomes. They had to make those changes. Half of those changes actually didn't go into effect after there was sort of pushback by folks on the ground. So I think it's really going to vary across states. I think it's a really good issue to watch, but I don't think we can determine right now where it's going to go.
3 more questions, then we're going to wrap up.
Well, I want to answer this.
Who are up there will get to you, but no speech. I'm not
Joanne,
saying.
I want to answer the caregiver question for Wisconsin specifically. So we've thought a lot about caregivers. So in the last biennial budget, we established a floor of how much you have to pay caregivers in Wisconsin, which actually has cost our Medicaid program a lot of money, but it is something that from a values perspective and an aging population is even more critical. So we are very much committed to continue to pay those caregivers. And then in terms of exemption in Medicaid, caregivers are an exemption, but again, there's some squishiness in that definition and how we're going to define and certify that piece. So there's a lot of work happening. We're waiting on the rule, but it is a place that we are paying close attention to because, I think they're just a critical component of our healthcare system, especially with aging populations in a state like Wisconsin. Yeah.
Okay, next.
Hi, Jessie Hellman with CQ Roll Call in DC. How are states thinking about people who are homeless? I guess some would maybe be in the traditional Medicaid population, but some might be in the expansion population. Is there a clear-cut exemption for them, or are states going to have discretion over how to handle that?
Yeah, that question has come up with some of the states we've been talking to. Many of them are in the expansion population. They will be impacted by these requirements. A number of states have been inquiring whether they could fall under the medically frail category, and we really need to wait, I think, for the interim final rule to know if that's going to be able to fit under that definition.
And I would add, so a caveat here is the SNAP requirements, work requirements, people who were homeless previously were exempted, and now they are not. So that's another piece that we are working through, again, waiting for that rule, but absolutely an issue.
Aparna Zalani, freelance journalist. I spoke to a family. This is a question about waiver programs. I spoke with a family with a medically fragile child. She's on some sort of a waiver program that provides medication and health care. Her mom is really worried that with the OBBA, the waiver program might be dismantled by the state. How vulnerable are these programs in both Medicaid expansion and non-Medicaid expansion states?
So how are they?
Would the waivers be reversed?
How vulnerable are these programs in these states, the waiver programs that are in several states?
So I think this is a separate issue. Again, we have a waiver, and most states have waivers in these spaces. I think, again, from the perspective of our Medicaid team and me, it's person-centered. So again, critically important that people keep access to their care, especially a caregiver, like a parent of a caregiver has medical complexities. Thinking about technology, how do we bring more services to where people are so they have more access? From our perspective in Wisconsin, I can say that's a priority. That's not something that we're considering being cut. Yeah.
Last question, and then you should all go to the members' meeting.
Hi, my name is Jamie. I'm with North Carolina Health News. My question is, how do you think that the implementation of the work requirements will play out maybe differently in states like ours, where Medicaid eligibility determinations are handled on a local level, rather, meaning, like local and county.
And you have 100
social
counties.
Services. Right, we do. They handle eligibility determinations rather than state workers. How will that approach kind of make a difference in the implementation?
Well, I will say North Carolina is not unique. There are a number of states that have eligibility determinations at the county level. California is one of those states. I will say from where I sit at the national level, it is a level of complexity, right, to have sort of this separate set of eligibility determinations in sort of a separate level of government. And I view that as a challenge with respect to resources and volume and all of that. But I don't think, I'll just to be honest, that I could predict today that because North Carolina has it, they're going to do worse than a state that has it all at the state level, because there's different challenges that are going to, I think, impact how successful this will be in various states.
And I can speak to Wisconsin. So we have a mix. So the state, we have an eligibility team that is based in our largest cities, so the city of Milwaukee in Wisconsin. And then we have these 11 consortia across the state, and each consortia is made up of a number of counties and tribes. But those consortia are actually county employees. So one county is sort of the employer of the consortia staff, but we do all of the training, and we do all of we make sure that everything that they're doing, they're accountable to the state standards, and we set those standards. We train staff as they come on board, and then we also do continuous training with them. So, there's a baseline across the state. And I know that is not necessarily the case in other states. So again, they are employed by counties for those 11 consortia, but we do all of the training and set the standard. And then we have our own eligibility in Milwaukee.
Okay, so I wanted to thank the two who did show up.
We just published Cody's paper that is about this very topic.
I was just going to say, and
so
there's a great paper.
I'll give it to you, Joanne, and you can upload it to the site.
Okay, thank you so much. Right, and then, it's really complicated, so we'll be revisiting it.